Live. Okay, good to be with you all. And we're here with you today on a couple of different platforms. We're on YouTube Live, we're on Facebook, and we're on Instagram. And I better double check because for some reason, Facebook was not cooperating properly with us last week, but the others worked fine. Let's just take a look and see. Yep, looks like we're good to go on all platforms. All right. So happy to see you all. It's a blustery, blizzardy Monday afternoon here in northern Minnesota. Back in Arizona here shortly, where we typically are. But yeah, I'd love to hear where you're from. We often hear people from just all different parts of the world. It's always kind of interesting to see where people are tuning in from. So Office Hours Live, if you've got key questions on your metabolic health, so hormones, blood sugar, body weight, thyroid, those sorts of things, I'd be more than happy to help out. And several of you sent in questions in advance, so I've got a bunch of those queued up, and I'll talk through some of those, and then we'll grab some of the ones that come in live. Let me move one more screen so I can see what's happening everywhere. Okay, there we go. Now we're good to see what's going on all the platforms. There we go. So this is a week of note. There's often the various times of special days for this or months for that. So this is the third annual week of recognition for thyroid eye disease. And I wanted to mention that real quick. I've got a few images here that will show up. So yeah, the Prevent Blindness Association has declared this is the third annual World Awareness Week for thyroid eye disease. This is a common thing, and it's very underdiagnosed and arguably could be much more thoroughly treated. So yeah, I'll mention this. I'm seeing a lot of folks come on right now. Good to see you, Joanne. Hey, Marilyn, welcome, welcome. And yeah, just staying caught up. And we got several from New York, Netherlands as well coming in. So yeah, all over the world already. That's pretty cool. So thyroid eye disease. Now, used to be called Graves' eye disease, but the difference is that now we know it's not part of Graves' disease. It very commonly associates with Graves' disease, but it's not caused by Graves' disease. It turns out it's an entirely separate autoimmune condition. And about half of folks with Graves' disease develop this autoimmune condition, but many people get it that don't have Graves' disease. Many can get it from Hashimoto's, from just general hypothyroidism, and sometimes, crazy thing, thyroid eye disease can show up without thyroid disease. Yeah, but this is a really big deal, and this has profound effects on vision, which can lead to actual blindness. But there are treatment options that are available and are effective, and it correlates with the overall autoimmunity. So the things that affect thyroid autoimmunity generally affect the autoimmunity behind thyroid eye disease. And specifically, the markers TSI, TBII, and anti-TPO, they correlate with the risks. So things that help them help Graves' eye disease. And we'll talk more about those. I'm seeing some questions come up already related to that. John's with us from New Mexico. You're welcome, John. Good to see you here. And many more coming on as well. So yeah, that's a special week we've got going on right now relative to thyroid eye disease and a special awareness week. So lots more good questions coming in. This is awesome. Weight with menopause, what causes that? Yeah, great. We'll talk about that for sure. Many more coming on real quick here too. A few more that were sent in advance. Let me just grab a couple of these, and I'll go back and forth between the ones that were sent in before and those that come in live. Yeah, seeing more of you all come on. Welcome. Hi, back. One that came in was, get this back up here, was about reducing antibodies. So would love to learn if reducing antibodies is possible, and would that result in reducing antibodies in general throughout the body, and what if diet and gut repair aren't enough? So this is interesting. Actually, later on tonight, I'm speaking with a group of medical interns about this same topic, and it's tricky. Hey, Kelly, hey, back to you. Thank you for the feedback. Glad you enjoy office hours, Kelly from Philadelphia. So it's a tricky thing. The gut is important to all facets of health. And there's a lot of really plausible theories on how some changes in the gut may start the whole process of autoimmune disease. And in trying to find ways to heal a disease, it makes sense, of course, to think about what are the causes of the disease, what gives rise to it. But it's tempting to think that if you know why something happens, that you know how to fix it. And the one sometimes follows from the other, but not always. Here's a silly example. Humpty Dumpty fell off the wall, right? And he broke apart. A seatbelt might have kept him from falling, right? But a seatbelt won't help put him back together again. So there are times where the things that address the cause don't change the effects. In many cases where they do, but we only know that when we see it well tested. So I'm all for anything that can benefit digestive health, that can lower digestive symptoms. But yeah, there's really not strong evidence that common approaches for gut repair reverse thyroid disease. There's no good evidence of that really being the case. Yeah, even though there's ideas that it might start from the gut, there's a lot of things that can contribute to a disease that if you change them, you don't change the disease. We know, for example, that of the things that give rise to thyroid disease, genetics are a big part of that. And yet we can't change genetics. So anyway, antibodies can be lowered. They can be very relevant. That can benefit overall health. And it likely does lower antibodies throughout the body. I don't understand that part totally. There is a risk for other autoimmune diseases, and thyroid antibodies actually do go throughout the entire body. And they do things that are not just tied to thyroid function. They actually raise the risk of heart disease. They can affect fertility. They can do a lot. So they can be lowered. The main things that do that are controlling iodine intake. We've got lots of good data on that. And then we've got good data about nutraceuticals being helpful as well. And looking through all the data on what's out there that can help, I came down with 3 things that have had pretty good quality, double-blind human studies showing that they work and that they're safe. And I combined those into antibody support. So I'll drop a link there to this, but yeah, these things have been clinically shown to lower thyroid antibodies quite dramatically and quite safely. So hopefully that was useful. Lots of good questions coming in. Many more people in live here. Let me grab a few of the live ones. Then we'll go back and forth between those and some that were sent in advance. Holly's got a great one about the MRD. I will certainly address that. I saw one from Joanne pretty early on up here. Joanne, who is a good candidate for deprescribing? You'd said it's best if your body produces more thyroid hormone than supplementation. I've had Hashis for 10 years. My ultrasensitive thyroid is mildly heterogeneous. So Joanne, yeah, there's things that make it more likely and things that make it impossible. So impossible is really just not having a thyroid. More likely, yeah, the more someone's own thyroid works, the greater their odds are of not needing thyroid hormones. But that's not absolute. So some of the papers on deprescribing took people who didn't have a lot of residual output. They were on medication that largely gave them all of what they needed. Some were on treatment for quite some time, and some had overt hypothyroidism when they were first put on treatment. And some of them still could come off. So the criteria I've talked about in terms of how much your thyroid makes, how long you've been on treatment, how big your dose is, things like that, those predict likelihood, but they're not absolute contraindications. So yeah, there's many people that have been on a lot of meds for quite a while, even at doses that are too high, that still successfully manage to come off. And even those that don't come off, the vast majority end up successfully needing less. And that's still a win. It's pretty clear from data that the more you make by yourself, the better in terms of a lot of facets of your overall long-term health. Okay, lots of good questions rolling in. Let's grab a few more of these live ones. Holly had one. Can you please clarify when we should or should not use fruit in shake on the MRD? Yeah, so the metabolism reset diet, there's the reset phase and the maintenance phase. So the reset phase is that 28-day cycle, and the maintenance phase is everything else. So everything else, fruit is fair game, no drawbacks to it. During the reset phase, however, better to avoid beyond the amounts that are used in the recipes in the book. It's not a bad thing, but part of what happens with fatty liver and difficult weight loss is there's too much fructose relative to glucose. So part of the MRD is also changing that fructose to glucose ratio, and that renders the liver more able to break down stored fats. Now, I saw someone ask a question and then a follow-up, someone saying that had a similar question. Let me see if I can't grab that one because it's obviously important. Oh, here's a great one. James is asking that, can you take thyroid medication and magnesium, or how long does one wait after taking Armour Thyroid? And then Cindy was saying, I was just wondering this, take my Armour around 4 a.m., take magnesium around 3 p.m. Okay, so Cindy, you're taking those a long ways apart. The general answer in terms of how long to take things after thyroid medication is an hour, a solid hour. Now, there are those that have a hard time keeping their levels stable, and they may not be absorbing well. And in those cases, there is data saying that some things may need more than an hour. And those some things include insoluble forms of calcium, like calcium carbonate, oyster shell calcium, bone-derived calcium, MCHC. That can also include calcium from dairy products, and that can include coffee, and then also antacids and iron. So those are things that for some people, they may need more than an hour between the thyroid medication and that thing. So yeah, lots of types of calcium, some types of iron, coffee, and then also antacids might require more than an hour. Now they might not. So if you're doing those things an hour later and your scores are stable, no worries. I would not encourage you to change that because it gets tricky to be on a complicated schedule with pills. Magnesium, James, is one to where an hour afterwards is expected to be fine, not really known issues, but you wouldn't want it with the thyroid medication. So the thyroid medicines, the active ingredients are microscopic. I was looking around to see if I often have a little salt cellar on the table, and a grain of salt, you can't see it anyway, but so 1,000th of a grain of salt is about 1 milligram, and a microgram is about 1,000th the mass of a grain of salt. We just can't even wrap our heads around that. But that's what thyroid hormones, that's how small they are, the actual amounts of them. And any kind of fiber or binder or filler or protein can make them not absorb consistently. So yeah, nothing with them besides water. The magnesium an hour later, totally fine. And again, for most people, that's not an issue at all. For some people, other things besides magnesium can be a problem even an hour later. And I can talk more about that if there's more questions about that. Follow-up, Joanne, the thyroid being mildly heterogeneous, that's not something that would say that one could not deprescribe. So if the ultrasound says the thyroid is severely atrophic, meaning it's badly shrunk and it's pretty much nothing left of it, that makes deprescribing less likely. But mildly heterogeneous is the very normal signs of there being mild signs of Hashimoto's. So no worries about that. Okay, let me grab one more that was sent in advance, and I'll get a few more of these live ones because there's a lot of good ones coming in live here too. So one that was sent in advance, going back to our next one here. Yeah, this one came up a couple times. I think it was a similar thing, but is there a toxicity for B6 in the form of pyridoxal 5-phosphate? And then another detailed version was saying that the person was taking it from my multi plus 25 milligrams of it per capsule from another supplement. So B6, synthetic B6 is called pyridoxine hydrochloride, and the body must convert that into the active form, which is called pyridoxal 5-phosphate. Now, dietary B6 is in natural pyridoxal forms, but synthetic B6 in vitamins is not always converted. And if it's not converted, it's harmful. It's actually neurotoxic. People can have numbness and tingling and burning in their extremities, painful. They can have anxiety symptoms. They can have bad fatigue. It can cause really marked symptoms. And it's really common to see people that have high levels of pyridoxine HCl in their blood. There's a lot of it in processed foods and supplements, oftentimes very excessive amounts. So I've talked about the dangers of that. And then I've talked about pyridoxal 5-phosphate as being a form that doesn't have those concerns. As far as how much P5P is toxic, so the studies that I've cited and talked about suggest that it's rather harmless over a broad range of common dosages. Now, Some papers said something about not having a known toxicity. I wouldn't buy into that. You can drown in water. You can drink so much water that your electrolytes are depleted. Toxicity is all about dosage. Everything has a range of where it can be toxic. But best we can tell, within a realm of reasonable and maybe even, uncommon amounts of P5P, not a worrisome thing. Having said that, it's always good to think through what one takes for supplements and avoid things that are redundant, avoid things that are unnecessary, and keep it more focused. It's always a good idea. Okay, lots of new good questions coming in. Let me grab another one here. And I'm looking at all the platforms, just kind of picking through. Let's see, here was a great one from Kelly. Hi, I gained 15 to 18 pounds when I hit menopause literally overnight. What causes that? I am really struggling. Had a slew of blood work, thyroid looks good, feel like I cannot get this weight off. Lose only a few pounds of MRD and no inches, all weight in middle. Eat very healthy between resets, dramatically changed diet 5 years ago. Don't think it's good. Waist is very thick. It's awful. Kelly, yeah, so menopause and weight gain, the changes of menopause and the timing of menopause are windows in which weight gain is common. And especially when it's mid-body and resistant and coming on with menopause, we think about adrenal health being relevant. So the biggest shift in menopause hormonally is actually a change in the adrenal glands. They make a compound called estrone, but normally in trace amounts. Once women hit menopause, the amount of estrone may go up just by tenfold or more from the adrenals. And that's the biggest driver between hormonally related weight gain. So patterns like you're describing often are matters of adrenal resistance. Now, having said that, if you're following through the MRD and not getting results greater than that, there's usually something that can be found through troubleshooting. I'm going to drop this link in here. I am available. I did open some times up this month and next month for personal consults. So if anyone wants to talk to me in person one-on-one, we can sort through things like that. And here I do my best to give general answers, but in a personal consult, we can talk about specific your situation. I can look over labs and all details and all needs and say, here's what's wrong and here's what to do, like specifically. So that's totally an option. Kelly, I am signing up. Yeah, Kelly, when you sign up, you'll have the option of uploading recent labs. If you got them, that's fine. If you don't, it's okay too. You can also do a screen share and show me things that you had access to. But we'll talk through this in great detail. And I'm confident we'll figure out what was the holdup with the MRD, why it wasn't working, and also some other ways in which the adrenals may be relevant or what else can be a factor. We'll completely talk through all of this, and I'll be happy to do so. Okay. Maritza, I've seen this question many, many times, the exact same one, Maritza. Someone having high fasting glucose with low A1C and low insulin. Thank you for your response. Happy to help, Maritza. If you want to make note and write this one down, that's just normal. It's not worrisome. So what happens is that when your fasting glucose is higher and your A1C is low, that's saying that long-term, your blood sugar is under good control. Your morning runs a little higher, but overall, you're doing fine. There's no big risks from that. So the morning fasting glucose is what your liver releases into your bloodstream. And if your liver releases way too much all the time, it will eventually cause the A1C to elevate. But some people have high glucose on occasion, and I'm sorry, that's not even high. Some experts say your morning glucose has to be below, some will say mid-90s, but it's really in the context of all things. So your A1C is more meaningful than the fasting glucose alone. So even though it's high there on occasion, because your A1C is low, you're not high often. You're not high enough often for it to be a problem. So A1C is also called glycosylated hemoglobin A1C, and it's quite specifically how much sugar is stuck on your red blood cells. The reason high blood sugar is bad is because it sticks on your red blood cells and it makes them sticky and it makes them disrupt circulation and lots of other problems. That's where the advanced glycosylated end products come from. So if your A1C is not high, occasional elevations of glucose don't really affect your health. And this is a funny thing. The 24-hour glucose testing now has gotten really popular. And I think it's great that people want to be aware of their health and track things and measure stuff. That's totally cool. But it's normal to have big changes in your blood sugar throughout the day. That's just what happens. I think people are given an idea that their blood sugar must always be in some super tight, narrow range. That's just not normal. That's kind of artificial. So yeah, blood sugar fluctuations. Now, of course, there's a point at where your blood sugar can be too high or too low. I'm not saying it doesn't exist, it exists. But a lot of the amounts of change that people are taught to be concerned about, we have good evidence that they're just normal and they're not worrisome. So all things together, Maritza, I wouldn't stress about that any further. That's totally fine. Let's see. West Texas greetings. Sorry, I'm late, Frankie. I was starting to wonder. Glad you made it. Good to see you here. Here's what I want to address too. This is from Sorab. I hope I'm saying your name close to correct. Forgive me if I'm not. What do you say about doing juicing for a period of time, like 21 to 60 days? Sorab, if you wish to share the goals behind that, so what would be the purpose behind juicing for 21 to 60 days? Please tell me the goals behind that, and I'm happy to give more feedback on that. People think about that for purposes like detox or weight loss or whatnot, or cleansing. If you want to tell me your goals behind that, I'm happy to say more about if it would work for that or not likely, or just more thoughts in general. So happy to see some follow-up comments with the goal behind a long juice cleanse. Okay, a few more that were sent in before. Let me grab another one of these here. Here is one that came in. This is a really good question. Can you please talk about iodine levels in organic dairy, and if there's difference in cow, sheep, and goat products like yogurt and kefir, which I would like to keep in my diet, although I have Hashimoto's. Currently, I eat 1 or 2 tablespoons of sheep yogurt per day, hoping this is not too much. Yeah, so overall, the data on iodine in a lot of dairy products besides cow's milk is limited, but the data that I found suggests that organic is not too different than commercial. I shouldn't say that. It's lower than commercial, but not enough to move it into a different category, meaning that if you're trying to reset and heal your thyroid, you'd still want to avoid organic dairy during that reset phase. Once you're in the maintenance phase, though, then 1 or 2 servings of dairy products can often do fine. And organic has advantages in lots of ways. Now, between different animals like sheep, goats, cows, even camels, again, not a lot of data points, but the ones I've seen suggest not big radical differences. Now, you're saying 1 or 2 tablespoons of sheep milk yogurt per day. So in terms of maintenance ideas, that wouldn't be a problem. But during the reset phase of reversing thyroid disease, you would want to avoid including even sheep milk products. But once you have stabilized thyroid function, that wouldn't be an issue at all. But yeah, good question about that. Okay, here's one about hormone tests. And let me grab some follow-up questions as well from John. For the B6P5P is 57 milligrams toxic. John, I did mention that one, and you were talking about the dosage. No, I know of no data point suggesting that it is. In terms of upward amounts, I have seen data arguing the questions. I always love those. Let me jump on this related one real quick. Clear this one out briefly. There we go. So yeah, so Frankie had one about iodine in dairy. Can you speak to Rome, Italy, if this would be a concern? From my understanding, they don't swab udders with iodine. Yes, thank you, Frankie. So the swabbing the udders with iodine is the main source. And I've not seen data either way on whether that's done in Europe or elsewhere. If you have, that's great. I've not heard. The other source is fish meal in cow food. You know, fish meal is often used as a cheap protein source. And then iodine directly fortified to cow feed, to cattle feed. Those are the main 3 sources. I don't know the exact practices in Europe, but I have seen assays of iodine in dairy products in Europe. And that's even more meaningful. You know, whenever you can know what you think would happen, like what are the practices versus what actually happens, like the measurements are what really matter, the actual outcomes. And yeah, I've seen the data. In general, it's pretty similar to the US. Sometimes it's slightly lower, but again, not enough in a way to make a big difference. So if a glass of milk in the US has, say, it's assayed to have 200 micrograms per glass, in Europe you might see 160 micrograms, and organic milk might be 130 micrograms. So those things can make it lower, but not enough to make it radically different for those trying to really heal their thyroid function. So yeah, I hope that was useful. All right. Just looking through, I've got a few more sent in advance. I'll just get this one quickly because I early along talked about Graves' eye disease. And Chris had an earlier question about this too. Yeah, can eyes react or become bloodshot due to thyroid medication or red eyes caused by the antibodies Hashimoto's? From thyroid medication. So the thyroid medication, assuming that the amounts given are appropriate, wouldn't really do that. Now, that's an assumption. I have seen cases of people where Graves' eye disease was likely triggered by an excessive dose of thyroid medication. So with Graves' eye disease, I mentioned how it's not caused by Graves' disease, it's an autoimmune response. Now, a bit of a paradox there is that autoimmune disease can be caused by hyperthyroidism. And with Graves' disease, that's called the hyperthyroid autoimmune loop. So once someone starts developing hyperthyroidism in Graves', then the extra thyroid hormones can worsen the autoimmunity, which worsens the thyroid hormones, and so on and so on. That's the loop side of it. Now, that hyperthyroidism and all the inflammation that it causes, that can also trigger the onset of other autoimmune diseases, including Graves' eye disease. And I'm aware, I've seen patients firsthand who were put on excessive doses of thyroid medication from other prescribers, and they developed Graves' eye disease from that. So Chris, that is possible. Now, as far as the antibodies from Hashimoto's causing Graves, causing red eyes, I'm not aware of that either way. I've seen a lot of folks that have had high antibodies. I've seen many studies about symptoms that come from high antibodies, and that just hasn't come up. So I wouldn't say it's not possible, but it's certainly not a common reaction. But thyroid medications, if they're in severe excess, can actually trigger thyroid eye disease. And it's not because the medications are foreign, it's because they're causing hyperthyroidism. And one of many bad things about hyperthyroidism is it can trigger overall autoimmunity. So yeah, good question. Happy to address that one. All right. And a few more that were sent in before. I'm just scrolling through these here. Yeah, we talked about those couple, and we talked about this is the other one that I wanted to get to as well. Yeah, so this is a question. If you suspect hormones and or thyroid are off, what test should one expect or want their doc to run? And I'll talk about that one. And just looking through, here's a possible related one. How long is it safe to remain on HRT post-menopause? I'll talk about that as well. That ties in. And I saw another one that back to what we're talking about with iodine. What do you say when doctors say you can have as much iodine as you want to, as long as you have plenty of selenium too? That's a great one. We'll talk about all those in just a moment. Let me get the iodine real quick because that's quicker. So Kate with us on Instagram is asking, hi, Dr. Christensen. I kind of read it quickly, but what do you think when doctors say you can have as much iodine as you want so long as you have plenty of selenium too? So there's a partial truth behind that. And the partial truth is that our iodine tolerance is worse if we lack selenium. So there's iodine requirements. That's like the lowest amount that we can consume before we're deficient in iodine. If we're below that, we're below our requirements. But then there's the iodine tolerance. And if we're above tolerance, we get harmful effects from that. Now, part of that tolerance is genetic and hardwired, and part of that tolerance is based on many other facets of our health. Our adrenal health can affect that, our levels of many nutrients like zinc and iron, but one of the foremost factors is our selenium status. So if our iodine tolerance is here and we're selenium deficient, it might be there. Now, a mistaken interpretation would be iodine is harmless as long as you've got enough selenium. No, there's still a point where you get too much, but it's easier to reach that point if you're also lacking in selenium. And this brings up a really important distinction. For those prone to thyroid disease, there's two scenarios, one of which is they've gotten exposed to simply toxic amounts of iodine. That happens. There's just way too much in some foods and some supplements, but that's not the most common scenario. The most common scenario is those who develop thyroid disease, they have more of an intolerance of iodine. So the amounts they were exposed to might not have been crazy. They might not have been amounts that were harmful for everyone, but they're amounts that are harmful for some people. So a lot of folks can consume a bunch and have nothing bad happen, but not everyone, and not those prone to thyroid disease. So yes, a lack of selenium makes someone even less tolerant of iodine, but that doesn't mean that you can just like bathe in selenium and like iodine will go off you like water off a duck's back. It doesn't mean that at all. But I've heard some interpret it that way. All right, let me go back to this other question here. So yeah, if you suspect hormones and thyroid are off, what tests should one expect or want their docs to run? So this is a question that always makes me think a lot. What tests did you have your doctor do? Well, here's the problem. I'll answer. I'll give a straight answer. But the problem is, if you've got to tell your doctor what to test, then at what point, then you'll have to also tell your doctor what the tests mean. You have to tell your doctor what to do about those results and how to interpret those results. So somewhere along the way, I don't know, if I'm flying in a plane to go somewhere, I don't want to tell the pilot what to do. Yeah, if you got to tell your doctor what to test, then you're just opening up a big can of worms. So you really want a doctor that knows what to test. But the other thought about this is there's often a perspective that hormone tests, that the results mean a lot independent of your health and your symptoms. And I've got to say, they don't. They mean nothing without the context of you and your health and your symptoms. So for example, if a woman says that, she's 52 years old, her menstrual cycle has just stopped, and she has hot flashes through the roof. Well, and then her blood tests show her estrogen levels are non-measurable. So those are things that could make her consider estrogen replacement therapy. There's more considerations. Not everyone's a candidate, but many are, and it can be safe in many contexts. So that would all fit. Now, on the other hand, if a woman is 65 years old and doesn't really have hot flashes, having a non-measurable amount of estrogen doesn't mean anything. That doesn't mean she has a problem. Doesn't mean she's broken in some way. That's just normal in that context. So yeah, so the important thing is, what symptoms are you talking about? What health concerns are you thinking about? If a woman has hirsutism, abnormal facial hair growth, and her DHEA levels are a little high normal, that can be important. Now, if another woman has high normal DHEA and no symptoms, that may not be relevant. So hormones matter in context. There's an idea that the blood levels mean a lot all by themselves, but they really don't. It has to be taken into account what the person's needs are. So, and then running the test, they've got to be interpreted in the context of the person's needs. And then the other thought is, then we've got to think about what to do with those results. So in the thyroid world, there's a lot of ways in which people can have symptoms, and those symptoms might be related to abnormal thyroid levels. There's like this normal range, there's this optimal range, and the data is really clear that if you're not in the optimal range, your thyroid might be causing problems for you. And it's tempting to assume that therefore taking medication to correct those levels would solve those problems. But the data has gotten really clear that the one doesn't follow from the other. Even if abnormal thyroid levels are causing symptoms, taking thyroid hormones won't necessarily reverse those symptoms. And a similar thing is true for many hormones. Even if they're abnormal, if they're low, for example, it doesn't always mean that putting more of those in the body is the best solution. In many cases, the body lowers hormones on purpose. Sometimes it's an adaptation. And so in those cases, adding more in is exactly what the body would not want. Quick example of that, many people have low levels of cortisol throughout the day. And sometimes doctors see that and think, oh, you're lacking in cortisol. And sometimes taking cortisol for people like that, sometimes they actually do feel more energized. They can improve some symptoms. But their body was not trying to do that. Their body was trying to keep it low as a way to relax and restore and heal itself. So that's the important thing about all of this. It's always a matter of, what is the body trying to do? What is the full context? What is the status of your health? What are your symptoms? All these things are just as important as what are the levels on the piece of paper. It all matters together. Okay. I'm going to grab one more. Kate See you at How Do You Health Fest. That's awesome, Kate. So yeah, coming up in first week in December. So about 3-4 weeks from now, this will be the How Do You Health Fest in Austin. If you've not heard about this, it's going to be a really cool event. This is going to be experiential. Kate, I'll be curious if you've gone before, if you have comments about the event. I'd love to hear your comments or insights about your experience there, and what you thought of it, and if you would recommend that for others. Please share a comment there. Kate's with us on Instagram, and I'll share her comment elsewhere if it comes up. But I think it's going to be a lot of fun. I've not been before, but I know some of the people that put it on. I'm close friends to some of those who have put it on, and I've recently met others who are involved with it. I think it's going to be a lot of fun. The idea is not to have it be a proper conference where speakers here, audience is there, but it's meant to be very interactive, very experiential, and just a great format. And this is a time where, everyone wants to be together in person again and reconnect and have the benefits of personal connection. So I'm really excited about that event. And here's a good one. I didn't close that all the way. I just baptized myself here. Yeah, one more. Let me grab this one. Why do you fast before taking thyroid tests? Why don't you take the thyroid test, take the pill before the thyroid test? So 2 questions in there. So fasting, there's data showing that fasting or non-fasting changes several of your thyroid blood levels. And when you're non-fasting, the effects on thyroid levels can be erratic and unpredictable. So if your tests are sometimes taken in a fasting state and sometimes taken in a non-fasting state, they won't be comparable. They'll be quite different in ways that are not always predictable. So fasting is a better, even more consistent baseline. Now, your thyroid pill before or after those tests, there's doctors that I respect that go both ways in this, but the difficulty is that when you take the pill before your tests, specifically T3 and T4 levels can quickly elevate. So starting as soon as an hour after you take those pills, T3 and T4 start to go up. And for the next 10 to 16 hours, they're higher than they are at their baseline. Now, one thought process is, well, but if people test at a set time, and if you know how many hours after the pill they were tested, you know where they would be on their curve. That's possible. However, there have been studies looking at how much individual inter and intra-individual variation exists. What that means is if I tested my thyroid levels 2 hours after taking a thyroid medication, and I did that 5 days in a row, would I always be the same at that 2-hour mark on each of those 5 days? That's intra-individual. Now, inter-individual is if Bob and Jane and Mary all tested 2 hours after they pill, will they all be at the same part of that curve? And in both cases, the answer is no. If you test yourself at the same time in different tests, it may not be the same. And different people are not the same. So that curve of that hour to many hours, each individual person and each individual sample could be anywhere in that curve. So it's really impossible to interpret exactly what a dose is doing, with the exception of what we call a trough level. So in pharmacology, there's peak blood levels and there's trough blood levels. So for a medicine that clears within a 24-hour cycle, the trough is before you've taken the pill in the morning. And the peak is the highest point that medicine absorbs. Some medicines have a very predictable peak. You know for sure the peak might be between 2 and 10 hours. For example, lithium is a medicine that has a known peak. So does Dilantin. So does some anticoagulants. And when there's a known peak, the testing is often given at that peak window. And patients are advised to test between this many and this many hours after the dose. But some medications do not have a known peak. The peak is quite variable. But the trough, the low point for thyroid medications, T3 and T4 are not gone. They're still in the blood 24 hours after. You're still higher than your baseline reading. So yeah, so trough readings are just more consistent like that. Okay, just taking a look. I was waiting to see if we had any comments back about the How Do You Health Fest from Kate. She must have signed off because she was at the end of that. But yeah, that's going to be a fun event. That'll be first week in December in Austin. I'll get links back up again too for everyone. Okay, so, oh, I just saw a comment back, Kelly. I never knew the adrenals change in menopause. Yeah, that's the big thing. Let me just touch on that a bit more. So, during menopause, before menopause, the ovaries are making estrogen, they're making some testosterone, they're making progesterone. Now, estrogen, there's different kinds of that. These are called E1, E2, and E3, or estrone, estradiol, and estriol. Now, the ovaries primarily make estradiol, but coming up into perimenopause, the amount they make becomes really erratic. It can be very high or very low. And someone asked before about testing and what to test for. So, if a woman is in perimenopause, it can be very hard to get a meaningful test result on her estrogen because it's so different from day to day. And in perimenopause, that's when the periods change, but they've not yet quit altogether. For the average woman, that's starting sometime in the early to mid 40s, and average age of onset for menopause is 50 years and 3 months. And of course, there's a lot of healthy variation of that average. Many healthy women still menstruate in their early 60s, not many, but some, it happens. And many healthy women quit menstruating in their 40s and late 30s for no reason, no problem. And for some, perimenopause can start in the 30s as well. So big range in that. But yeah, perimenopause is these bursts of estradiol and eventually waning down to less and less. Progesterone is also waning down during perimenopause and fading out. But what's happening is the more the ovaries make less estradiol, the more the adrenals make estrone to compensate. Yeah, the ovaries make estradiol, the adrenals make estrone. Estriol primarily comes from the placenta when a woman is pregnant. But the adrenals kind of almost like the ovaries pass on the baton to the adrenals. And the better the adrenal reserve is, the healthier the adrenal function is, the more smoothly a woman goes through menopause. The fewer symptoms she has of hot sweats or night flashes, the less tendency she has for weight gain. Many other things can affect her symptoms besides that, but that's the biggest single hormonal factor. So really big connection that way. Let me grab one more real quick here. This is from Tristan Harris. Tristan taking propylthiouracil, 50 milligrams a day for a while. Endocrinologist keeping me on this dose another 2 or 3 months for testing me again. Most recent bloods this week were T4, T3, TSH 4.09. Definitely heading towards hypothyroidism now. Do you think this is a good decision on their part? Tristan, yeah. So there's many facets to your care that your doctor knows that I don't. I won't second guess your doctor. As a generalization, when someone does start getting hypothyroid, that's a sign saying that they can move toward less treatment towards hyperthyroid treatment. Propylthiouracil is one of the 2 medications commonly used for slowing the thyroid. With hyperthyroidism, part of it is the complications from the excess thyroid hormone, part of it is the autoimmunity, and part of it is the change that takes place in the body's inflammatory control pathways. So a useful thing is hyperthyroid support. I'm going to share a link to this bundle up here. There's so much good data about nutrients, nutraceuticals having good effects on benefiting hyperthyroidism. And by benefiting, what I mean specifically is helping someone recover more quickly, helping them need less medication, helping them have fewer complications, preventing them from being harm or damage to the heart. There's good data on all of these things from nutraceuticals, and hyperthyroid support is for that. But in general, yes, as someone gets hypo, they are better off to start withdrawing on their treatment. And the better they're doing on low iodine diet, the easier that goes as well. So what propylthiouracil does is it slows the thyroid from absorbing iodine. And the less iodine coming in, the less there is to slow. So the better it all works. So yeah, going on the thyroid reset diet, using hyperthyroid support, those go a long way towards benefiting the recovery of hyperthyroidism. Okay, so that's what we got today. So next week, back for Office Hours Live, and we'll put the post up for questions we sent in advance. Those are always great. When those come in beforehand, I can take some time and share images and prep for those and have better data to give. I do get some questions that come up that are things that I simply don't know about. Someone was asking about lichen sclerosis recently. I'm aware of it. I know what doctors should know about it, but as not being a dermatologist, I have no detailed insights beyond what you would find from just Googling or looking in medical textbooks. So many things I don't address, and I'll try to at least say that or share that with people. The things that I do know about, I'm really happy to share clinical experience, a good sense of medical literature, and also just ways to treat things effectively and naturally. So yeah, put those up in advance when you can, and happy to see you guys next week. We've got holidays coming up pretty quick, so we'll be missing a few weeks for some stuff like that, but next week we'll be back. In the meantime, though, take great care. Post link for questions, please. Yeah, Frankie, I put those up each Monday, Sunday or Monday, the team puts those up, but honestly, anytime you can post those on Facebook or Instagram, just, hey, Dr. C, just put up the question. That's totally fine. I watch for that. I'll often give quick answers on the spot, but some things do well with more detailed answers. And so I'd love to also pull them out here and just talk to them about you guys in person. Okay. I'm seeing a lot of thanks come in. You're welcome, you guys. A great one just came in about natural ingredient or food that would replenish estrogen during menopause. So quick answer, nothing replenishes estrogen, but lots of things help benefit the changes in estrogen. And I've actually got a cookbook coming out in a few more months, the Healing Hormone Cookbook. And it's based upon just that. So many food categories we know benefit the changes in estrogen and lower the symptoms of perimenopause and menopause. So stay tuned for more about that. In the meantime, we'll see you guys real soon. Take great care. Bye-bye.